RetinaRounds, episode number 148. ILM Staining with ICG. Indocyanine green effectively stains the ILM, thereby facilitating visualization and potentially improving surgical efficiency. While ICG can be a lower cost alternative to brilliant blue dye, its use for ILM staining is off-label and may increase the risk of RPE, retina, and optic nerve toxicity. Let's take a look at ICG usage in today's case, shared by an anonymous surgeon. At the end, we'll discuss the safety concerns with ICG and some best practices when using ICG to stain ILM. So this patient is a 50-year-old male, a -6 diopter myope with 3 months of blurred vision in the left eye. Baseline vision is 20/70. The patient has a mild nuclear sclerotic cataract and a PVD. You can see on the OCT the presence of a full thickness macular hole without an elevated cuff and minimal CME at the edge of the hole. And the patient is scheduled to undergo a vitrectomy with ILM peeling. So let's check out the case. Okay, getting started with the case here, you can see that the trocars are being placed. Now this is a 25 gauge instrumentation that's being used, and you can see that the surgeons are using a technique that we've described in prior videos, this beveled entry, although I would like to see a little bit more displacement of the conjunctiva. You can see here that those trocars are being placed, the infusion line is placed, and now under wide field visualization, a core vitrectomy is being performed. Now you'll remember from the OCT that the posterior vitreous detachment is already present. It's always a good idea just to double confirm, and you can see the surgeons here placing some triamcinolone into the vitreous cavity. That's going to help to confirm that the hyaloid is in fact up over the posterior pole, but will also help with visualizing the peripheral vitreous during this part of the shaving. Now this patient is phakic, and so the surgeon is performing all of the vitrectomy on the nasal hemisphere of the eye using the right hand. You can see some of this peripheral shaving that's being performed. Some additional shaving will be performed with scleral depression towards the end of the case. And now once the vitrectomy is done here on the nasal aspect of the retina, the hand is switched so that the left hand is now holding the vitreous cutter, and the vitrectomy can be completed over the temporal hemisphere of the eye. Now once the vitrectomy is performed, the surgeons are going to instill some ICG over the posterior pole to stain the ILM, and I want you to pay attention to the technique that's used here. Look at this. You can see the ICG is a jet that's being injected, but it's being directed initially right towards the macular hole, and this is something that you'd want to avoid regardless of the type of dye that's being used. The jet of the dye towards the macular hole can cause damage to the RPE and potentially to the photoreceptors at the edge of the hole. But also with ICG, because there are some toxicity concerns, which we'll talk about more at the end of the case, you'll want to keep that ICG away from the macular hole as much as possible, just instilling the ICG over the parts of the macula that are away from the macular hole. Now, one thing I do like is that they've injected the ICG and they immediately removed it. Again, that's going to help to decrease the risk of any ICG-associated toxicity. And now using a pinch and peel technique, the ILM is being fractured here. I generally like to start more in the inferior macula, but these surgeons have opted to start in the supranasal macula and this sort of semi-lunar flap that's being created here. And that the purpose of this is to create a broader edge so that the ILM that's being peeled over the macular hole comes off in one large sheet. So you can see here that this semi-lunar edge is being extended over nasally towards the optic nerve and now towards the superior macula, and now grasping this broader edge right in the middle, you can see that the ILM can be elevated here. And I think you can appreciate that the staining of the ILM is quite good. So you can very nicely visualize the ILM. And this is a very beautiful broad flap of ILM that's being peeled. The surgeons here have opted not to use an ILM flap, which is certainly reasonable given the relatively small size of the macular hole, although there are some features such as the lack of an elevated cuff and the relative lack of intraretinal fluid that may confer a lower likelihood of macular hole closure, but certainly just peeling the ILM and not using flaps is a reasonable option in this case. But you can see a very nice visualization of the ILM using the ICG dye, and even with the fainter staining of the ILM, you only need some contrast between the ILM where it is peeled and where it has not yet been peeled. So even if you can't quite see the green stain, once you fracture the ILM, that contrast between where it has been peeled and where it has not been peeled is usually sufficient to be able to complete the surgical procedure. Now, again, as we discussed previously, some peripheral shaving is being performed. A number of benefits of performing a peripheral shave with scleral depression. First, certainly removing the vitreous there can decrease the risk for any breaks that can happen with vitreous contraction at the base. Also, it allows for good visualization of any peripheral pathology that may need to be treated. And last, it's going to create more space in the vitreous cavity for a full gas fill. Now, once the peripheral vitrectomy is completed, a complete air fluid exchange is being performed. And the choice of tamponade in this case is SF6 gas, which is, again, a very reasonable option given that this is a relatively small-sized macular hole, and that completes the case. And this patient did well with a successful closure of the macular hole. Now, here are some take-home points. As you can see from this case, ICG is an effective stain of the ILM. And as we've discussed previously, good visualization allows for better surgery. And visualization of the ILM can potentially make the surgery more efficient and lead to less iatrogenic trauma to the retina when fracturing and peeling the ILM. And while many surgeons have switched to brilliant blue dye to stain ILM due to its on-label status and safety profile, ICG is still used by some surgeons since it is potentially a lower-cost alternative. The concern, however, is that ICG can be associated with toxicity. For example, visual field defects have been reported. With respect to phototoxicity, while that can happen in any retina surgery, especially macular surgery, there is some evidence that ICG may potentiate phototoxicity. The dye itself can persist for many months after surgery. And finally, both animal and human studies have shown the potential for RPE, ganglion cell, and optic nerve toxicity in association with ICG. Now last, ICG itself may make the ILM a bit more stiff, a little bit more brittle, and that makes it more prone to fracturing into strips during peeling, although interestingly that did not appear to be an issue during this case. Now if ICG is being used, here are some best practices to maximize safety. First, you'll want to use the lowest concentration possible to visualize the ILM. Remember that a dark green stain is not necessary, since once the ILM is fractured, even a light stain of the ILM can provide enough contrast to aid in visualization. And the ICG comes in a vial of 25 milligrams, along with a 10 cc bottle of solvent, which is just sterile water. And mixing the two gives a concentration of 2.5 milligrams per milliliter. Now, this solution can then be further diluted in a 1:10 or 1:20 ratio to give a lower concentration, and that's going to be up to the surgeon preference. Now remember too that when injecting into a BSS-filled vitreous cavity, which is about 4 cc's, the dye will further be diluted, and that will depend on the volume of the dye that's injected into the vitreous cavity. Now, using an isoosmolar solution can improve the safety profile. Remember, the aqueous solvent with sterile air is hypoosmolar, and some surgeons favor mixing with either balanced salt solution or D5W. A D5W has the added benefit of being heavier so that the dye pools over the posterior pole. But you'll want to make sure that the OR staff uses D5 and not D50, which of course is hyperosmolar. Now, when injecting ICG, or any dye for that matter, you want to avoid injecting towards the macular hole, especially with a relatively strong jet, as was seen in this case. Once the ICG is injected, it should ideally be removed immediately. Now, some surgeons perform an air fluid exchange and then place a few drops of ICG solution over the posterior pole. However, this can increase the effective concentration that the RPE and retina is exposed to and may worsen the safety profile compared to injecting into a balanced salt solution filled eye. Last, it's always good practice to hold the light pipe away from the macula and to minimize light exposure duration during macular surgery. Now, digital viewing systems with digital light filters can be useful to minimize the amount of light that's necessary to get good visualization of the ILM. We want to thank the surgeon for sharing this case. ICG use has been declining in recent years, but we hope this safety review can be helpful to you to mitigate risk if you plan on using this dye. Thanks for watching. If you enjoyed this video, please visit us at RetinaRounds.com. There you can sign up for our email list. You'll get a notification every time a new video is posted. And if you have an interesting video or a tip or trick that you'd like to share, please follow the links on our website and you can upload your video there. Thanks so much for watching.